we've talked about kind of a historical case, although not that long ago. And then we've talked about how decision-making has changed and will likely continue to change as new studies emerge even this year and next year. Probably one of the more exciting pieces of data to share is an epidemiologic piece of data. And that is the fact that despite no change in the incidence of ovarian cancer, and unfortunately no change in the mortality, in the United States and in Europe, we're seeing a higher prevalence of ovarian cancer than we've ever seen in the past. And so you might ask yourself, well, how is this happening? If we haven't changed how often it's happening and we're not changing how often patients are dying, how do we have more women? Right now, if I look at what the prevalence is, how are more women with ovarian cancer existing right now than ever in the past? And the answer to that is because we have done a great job with maintenance therapies and novel therapeutics and supportive care, so better supportive care, in not with one single trial, but with successive lines of therapy, it just continually eking out longer and longer kind of durations of response, stable disease, progression-free survivals, so that patients who present to our practices now are often those who have received 3 and 4 and 5 and 6 lines of chemotherapy and are still, fortunately, well and working, and they want to try new things. And this is a very different scenario than I think we've experienced in the past. And so it presents some challenges because while we have a big lineup of chemotherapies that have been in existence and approved for decades, the efficacy of those therapies in these later lines of therapies is relatively poor. And that really hasn't changed over time. So it's not that patients are all of a sudden responding to topotecan, because they are not. In every clinical trial that we have done with topotecan, and I am being a little negative about topotecan, but every clinical trial that we have done shows that its response rate is less than 5%. So it's not that the tumors have changed, but we're using different drugs. So we have this lineup of chemos that are there, but if you look at just those, and you look at someone who's in the 4th line, say, or beyond, the expected response rate in that population is somewhere between 10 and 15%. Response rate meaning when I look at the CT scan before I treat the patient and I can see some tumor and I can add it up with RECIST measurements, does that shrink by 30% at any point during the treatment? 10 to 15% of the time it does. And those responses, if they occur, are very short-lived. So really you make it to maybe 1, or if you're lucky, the 2nd disease assessment before the patient progresses. So this is, because we have women living longer and presenting at these later lines of therapy, this truly is a situation of high unmet medical need where we really need to develop therapies that are tolerable, especially for women that have seen, if you've seen 3 lines of chemo and you have residual toxicities, what am I going to give you that works but doesn't harm you? So tolerable, effective therapies that really provide meaningful prolongation of that progression-free survival, a very high unmet need that fortunately we're starting to answer with new drug development.